experiences, thank you. In our lived experiences, we feel or we experience discrimination in many places. We feel it in clinics, we feel it in the broader society, and it discourages us from returning to care. It discourages us to be effective in workplaces or where disclosure is not supported, and in the broader communities, it brings us fear of exclusion. As I've said earlier, stigma and discrimination is always with us, and they continue to undermine every effort to close the gaps in treatment access, adherence, and viral suppression. For the Zero Discrimination Day, we cannot fight HIV if people living with HIV are still treated with disrespect in healthcare facilities, and in places where we thrive. Addressing stigma and discrimination is a requirement for us in achieving equitable treatment outcomes and for us to ensure that no one is left behind. So thank you so much, everyone, for joining us. Before we proceed with our convening formally, I'd like to welcome our co-executive director at GNP Plus, Florence Riacana, to set the scene for this convening. Florence?
Good afternoon, good morning, good evening, everyone. Thank you so much, Inad, for this very well-organized webinar, and to everyone for joining us today. Indeed, doing this PLHIV convening to align with the World Stigma Discrimination Day, that is to be marked on March 1st. I think it's an interesting period we are in which we have so much progress to be happy about and excited about, but currently seated in a very constrained environment that is threatening our community work, that is threatening, for many of us, privacy, safety, dignity, and for many, heightening our experiences of stigma as well. So just to situate that we have so much to celebrate, but that which we can celebrate is also in some dire risk in a very constrained environment in terms of space, civic space, the space to engage, but also the resources to be able to address and do our work. However, I was tasked to set the scene, but also to sort of share a little bit from our People Living with HIV Stigma Index. The People Living with HIV Stigma Index is a unique community-led tool. I first knew about the People Living with HIV Stigma Index while sitting in my country, Kenya, in 2009. And I believe I was interviewed in that period, and then soon after participated in organizing our community at the time as I worked in the Kenya Women with AIDS, Kenya Empowerment Women with AIDS. And we moved from that data to do a lot of work in terms of addressing the shifts and changes legally at country level. We were able to pioneer with a lot of other leaders in place and partners and lawyers and the UNAIDS and its co-sponsor UNDP, a lot of movements at country level. So the PLHIV Stigma Index did not just become a tool for us to share our stories of pain and shame in experiencing stigma at the time, but we watched it transform from a data collection, a research document, into shifts and policy decisions that led up to Kenya having the HIV Prevention and Control Act, having a HIV tribunal that listens to cases around HIV, people who are feeling that their rights and their disclosures have been violated are able to seek recourse. And this has transcended into so many countries. My story is one of many. All of you in this call and beyond can be able to share. However, from the People Living with HIV Stigma Index, we've been able to show what data that is led by communities and stories gathered from communities can be able to do. From the report, the global report that GNP Plus organized under the Stigma Index International Partnership that includes GNP Plus, the International Community of Women Living with HIV ICW, UNAIDS, and and I think there's one partner whose name I'm missing, but I won't go into now. This study looked at the stigma indexes from 25 countries between 2020 and 2023 that involved over 30,000 people. A few key things come out of this report. The stigma index is led for and by people living with HIV. Because we've been able to secure some standardized process that centers people living with HIV, JIPA is led and lived within the stigma index. Number two, high treatment access may be available, but interruptions persist. I think from the stigma index, we are even able to understand how access may not necessarily mean reach, or availability may not mean access. 93% of the respondents had been on treatment. However, 27% in this report had talked about interrupting treatment or stopping altogether because of aspects of stigma and impact on mental health, which affected adherence. Internalized stigma emerged as a very key issue of concern. Many years later, the impact of stigma on people living with HIV lives on in us, in how we are, who we become, and how we access treatment. Many people feeling ashamed, guilty, there's a lot of self-blame, and all of this requiring us to be very intentional about having stigma, HIV and mental health services included. I think in closing, one more part, key population face disproportionate burden. And if we are sitting in the HIV response, being very clear about following the science of compounded stigma for certain populations, men who have sex with men, transgender people, people who use drugs, sex workers, must be addressed with its unique responses given to them. Unique stigma that is faced by women, that is faced by people who are aging with HIV, particularly now as we start to integrate HIV into broader public health, will be critical to measure, to identify and highlight, and to seek redress for. As I close, I hope this meeting is a start of a lot of conversations we can have now moving forward, to imagine what stigma index is needed moving forward, that is country-owned, that continues to put JIPA principle into practice, but does not take away the work around sharing the experiences of people living with HIV and those affected by HIV in shaping how our health services and our social lives affected by HIV are coming together to ensure we have person-centered care in the HIV response. Thank you, and back to you, Enad.
Thank you so much, Florence, and for giving the information or background on Stigma Index. I see that there are a lot of conversations happening in the chat. We have before anything else, we have a French translation. If you click on the globe icon and then choose French translation, and then choose your language or choose language. For the rest of the evening, for the rest of the convening, we will have different experiences on conducting Stigma Index at a country level. And I also invite our participants who have experiences in Stigma Index, especially in the Asia region, to also share experiences later. But for now, we want to hear from Clayton Eusebio de Lima of UNAIDS on the significance of Zero Discrimination Day, which is this coming Sunday. And following from Florence, what can Stigma Index continue to serve as a powerful PLHIV-led tool for sustainability of HIV programs? Clayton, over to you.
Thank you so much, Enad, and thank you also, Florence, and for the invitation. Congratulations for GNP Plus for this event of celebration of the Zero Discrimination Day. Thank you for, I think, more than 90 participants that are here from all the regions. Good day, everyone. I would like to start saying how I was thinking how the first UNAIDS established the Zero Discrimination Day, and it was first commemorated in 2014. In 2014, 12 years ago. And then imagine how the world was 12 years ago for for everyone and also for the HIV response, and how, as Florence was saying, how much we had things, advances to celebrate, like new treatment options for people living with HIV, new prevention methods available. But despite all these changes, and of course, this is very much success of the leadership of people living with HIV, but in the area of human rights and in the area of stigma and discrimination, even though maybe we can see some advances, including of how the U equals U has been used as a powerful public health strategy as well, but we still see in many countries high level of stigma and discrimination affecting people living with HIV. So I think that is the importance of this day, to show that we have progressed, but that we still have a lot of work to do to address how stigma affects the life of people living with HIV and affected by HIV in their daily life. This year, the theme it was chosen for the celebration is People First. And this theme, it really aims to shine light on how the persistent discrimination faced by people living with HIV undermines access to health services, violates rights, and holds back progress towards ending AIDS by 2030. I think we can say with confidence that, unfortunately, stigma and discrimination are among the main barriers that are preventing countries reaching the 95 countries. Or even in countries that have achieved it, we know that, and Florence mentioned that, how also intersecting forms of stigma related to age, related to gender, sexuality, drug use, sex work, this will put some populations further behind and also affects their ability to access HIV treatment. And I think that's why in the new Global AIDS strategy that was adopted in December last year, ending stigma and discrimination and promoting human rights is one of the result areas and one of the priority areas in the strategy. I think Florence said already how about the data of the stigma index and the importance about this data. I would like to mention how for UNAIDS and for the monitoring, maybe some of you know that we have the 10-10-10 targets. And these targets, they are not only in the Global AIDS strategy, the previous zone in this one, but also in the political declaration. And one of the targets is that we should have less than 10% of people living with HIV experiencing stigma and discrimination. And how we monitor how countries are progressing regarding this target. This is with the stigma index data. So the stigma index data provides really critical information for countries to monitor how they are advancing in ending stigma. UNAIDS is very proud to be a partner and have been supporting, working with national networks, and also globally with GNP+, with ICW, and also with Johns Hopkins University in the last years in providing technical support to the implementation in many countries. I think we have a challenge now. I think responding a bit the second question in terms of sustainability is how, in this context where we are seeing reduced resources, especially for this area for human rights, for stigma and discrimination, we are seeing less resources, how we can still push forward this work that I think it's more important than ever, including when we think about the integration of HIV services with broader health services. So monitoring this, the quality and monitoring to make sure that these services are provided without discrimination is more important than ever. So UNH stands with you to have this discussion, and including of how we can make the Stigma Index more sustainable, as Florence said, more country owned. So we are ready to support in this work, and I'm looking forward to listening. I think what we will hear today is also another way of how we can make this more sustainable. Is really showing how this is much more than a research. It's really a tool to change policies and to improve the lives of people living with HIV around the world. So I think I will stop here. Thank you very much, Ned.
Thank you so much, Clayton. And I don't know how to remove the timer on my screen. But that's okay. Thank you so much for mentioning that the stigma index is more than a research, but a tool to change policies at the country level, especially now that we are going towards integration. And the discussions of sustainability should also bring us into more high-level discussions on what we want stigma index to be. And how to make it sustainable at the country level. Thank you so much, Clayton. Now, following Clayton's intervention and thoughts about the global significance of Zero Discrimination Day, saying that stigma and discrimination remains the barrier in achieving the targets or making sure that the PLHIV have access to treatment and virally suppressed. We're now going to the countries. We have our colleagues from Kazakhstan, Philippines, Sierra Leone, and South Africa. But first, let's go to Kazakhstan. We have Batirbrek, Asembekov. In Kazakhstan, what are the most significant stigma trends revealed by Stigma Index exercise? And how were these findings used to influence programs, policies, or advocacy, or any stories how this data or community-led data were used in negotiating with governments to ensure that there is integration of HIV services in a broader public health. Over to you.
Thank you, Inat. Good afternoon, colleagues. My name is Batirbrek Asembekov. I represent here Central Asian Association of People Living with HIV. I assisted Central Asian Association with organizing and conducting last 3 Stigma Index studies in the country. Thank you very much for the invitation. Our team was pleased that Kazakhstan was invited to share its experience at this important meeting. For us, it's important that Kazakhstan and Central Asia are visible in the global HIV community, and we can contribute to shared learning. You have probably seen the UNAIDS map showing the countries where the HIV epidemics is still growing. So on this map, you can see large red area in Central Asia, that is Kazakhstan. So let me present. So some country context. Kazakhstan is a Central Asian country, a large country with low population density, 9th largest country in the world. Population is about 20 million. We have 20 administrative regions. There are large distances between regions that affect organization and logistics of services and research. HIV distribution is uneven across regions. HIV distribution, some regions have historically a higher HIV prevalence linked to historical patterns of drug use and urbanization. Now I briefly describe the HIV situation in Kazakhstan. An estimated 43,000 people live with HIV in the country. HIV is concentrated in the key population. We have good progress towards 395 targets. 82% know their status, 90% receive antiretroviral therapy, 94 virally suppressed. Important thing is that the government covers more than 95% of HIV program cost, and antiretroviral treatment is fully funded by the government. So, history of the stigma index in Kazakhstan. First study was conducted in 2015. Here, it included 3 regions and about 400 participants. The second study was conducted in 2021. This was the first study using Stigma Index 2.0 methodology, and they expanded to 10 regions and 1,143 participants. All 3 studies were organized by the Central Asian Association of PLHIV. Latest study is the latest stigma study included 1,379 participants. A study was conducted in 11 regions of Kazakhstan. These regions include about 88% of all people living with HIV in the country. We used standardized stigma index questionnaire, and for the first time, we also included in-depth interviews to better understand real experience of stigma and discrimination. So here, main findings, but it's not like main findings. We selected some of the findings. So about 1/4 of respondents reported that HIV negatively affected their self-confidence and personal life. Many respondents reported self-isolation and avoidance behavior. Fear of disclosure remains one of the main problems. About 10% reported skipping medication because of fears that others would discover the HIV status. Healthcare stigma remains significant. More than 16% reported being tested without their knowledge. In HIV cleaning, some respondents reported disclosure without consent and negative attitudes. An important finding is that stigma is higher in general healthcare than in HIV clinics. A respondent reported gossiping, disclosure without consent, and denial of services. Key population affected the most, for example, non-consensual disclosure in general healthcare was reported by 55% of people who use drugs, 42% of sex workers, and 29% of men who has sex with men. So let me describe how we used findings of this study. So first of all, after the study was completed, Central Asian Association of People Living with HIV took the lead in presenting the results to national stakeholders. The Central Asian Association organized national meetings where the findings were discussed with government institution, community organization, international partners. As a result, Central Asian Association with partners developed a national advocacy plan on stigma and discrimination for 2024 and 26. Some of these activities addressed stigma and discrimination included in stakeholders' work plans. Key measures included in the National HIV Roadmap 2024 and 2026. working with government. So as I mentioned in previous slide, Central Asian Association developed an advocacy plan, and based on this plan, the Central Asian Association worked with Ministry of Health and other government institutions. In general, Ministry of Health and its affiliated health organization understands the importance of addressing stigma and discrimination in the public health context. For example, Central Asian Association successfully supported approval of training guidelines for doctors and nurses that includes models on stigma and discrimination. Based on these guidelines, Central Asian Association together with HIV clinics conducted a series of trainings for healthcare workers. Some internal Ministry of Health documents, orders are also being reviewed. However, these processes are not always easy. I mean, Ministry of Health and required a lot of cooperation and communication with Ministry of Health. But more importantly, cooperation outside the health sector is more difficult. For example, there has been limited progress in discussion with law enforcement authorities on the discrimination of HIV transmission. Work with social services authorities is also challenging. Some internal regulations still limit access to social services for people living with HIV. So, in conclusion, I say we have some progress, but maybe it's not so big progress, but by step with health sector, but it is all complicated with work with outside of health sector. So I almost complete my 10 minutes. Thank you.
You are on mute, Inat.
Inat,
I'm sorry. I was
okay.
sorry.
Great.
I was excited to speak.
Yeah.
I was just saying thank you. Thank you so much, Batirbek, for that very informative presentation in the Kazakhstan context. But there's one question in the chat that I would like to ask now because it is linked to your last presentation slide. From Shakina Rose, USA. She asks, do people living with HIV in Kazakhstan experience HIV criminalization laws? And if so, does this contribute to stigma for people vulnerable to HIV getting tested? That's the question.
2 days ago, I saw a news regarding HIV criminalization. 2 transgender people were convicted to HIV transmission 2 days ago.
Oh, so there is, okay.
Yeah. So in the news, they it's I apologize, but it's hard to explain.
That's okay.
Yeah, this process, I was shocked because it was publicly addressed that 2 transgender people disseminate HIV.
Yeah.
Yes.
So Shakina mentions that she will look into this, and thank you for informing us. And thank you. I just looked into the information. Kazakhstan is still eligible for the Global Fund grant, and I hope we can use this information to support your country grants. Thank you. We will have discussions later, but for now, now from Kazakhstan. Let's go to the airport, let's board the plane, and let's go to the Philippines. We have Dr. Elma Laguna, who has supported the PLHIV Stigma Index study in 2019, and she's here to share the context in the Philippines. Dr. Elma?
Yes. Good afternoon, good evening, or good morning. Good day, everyone. So thank you for the invitation. I just got the invitation actually like 3 days ago. So I'm so sorry. We did a study in 2019. So this is a caveat that I have to review because it's been a while. So many things have happened. I move on to other research agenda also, but still this is something close to my heart because I know there are still tasks that were left unanswered, questions left unanswered. So I'll just go straight to the question that was raised. What's the okay? When we did the 2019 PLHIV Stigma Index study, so we were able to cover major cities: Metro Manila, Cavite, Angeles City, Iloilo, Cebu, Davao, and we had a total of 152 respondents at the time. So the first one, which was done in 2008, it was 80 for possibly selected respondents. The same sampling approach also was used. We rely on our networks to be able to identify respondents. So and of course, if you're familiar with the Stigma Index study, they have very strict protocol. For example, on the choice of interviewers, that has to be PLHIV also, and even the coding, they have a system of coding. But when we were thinking about the analysis, for example, it's called the Stigma Index study, but the study actually did not offer how to estimate the index. There was no index estimation. So I think that's one. I will be my contribution, I think, is really more as a researcher who has done data analysis on this topic. So we followed the ethical guidelines on informed consent as was in the HIV stigma guide. And the principle of informed consent required that the researchers need to inform the interviewee about the nature of the study, and for sensitive issues, only verbal consent respondents were obtained. So the limitation is definitely because of the lack of sampling frame. It hinders the generalizations from the survey findings of the study. And the study also failed to cover experiences of PLHIV in the rural areas and those who most likely do not have immediate access to information drives, trainings, and seminars. Okay, what happened? How come I can't move it? Okay, sorry. The Stigma Index study also failed to cover PLHIV from higher socioeconomic status and the requirement to strictly adhere to the structure or format of the survey questionnaire to ensure standardization and comparability with index studies from other countries hindered the research team from substantially rephrasing and asking follow-up questions that could have been the key to capture and present nuances in the Filipino experience with the global and standard questions, which the global and standard questions could not fully cover. So there are 8 sections in the SIS questionnaire. So if you look at the major findings, it's to answer the questions, was the major trend. In general, there was a low report of stigma and discrimination among the respondents. So among those who did experience stigma and discrimination, most of them reported experiencing being the topic of gossip of other people or receiving discriminatory remarks from other people. This is followed by receiving discriminatory remarks or being gossiped about by family members, verbal harassment, refused employment, or losing source of income and being blackmailed. So this is from the 11 scenarios that was presented in the questionnaire. So from there, what we do is, in order to quantify the severity of the stigma and discrimination experienced by respondents, we came up with an index based on the 11 scenarios of discrimination in the questionnaire. So as an initial step, what we did was to create a discrimination index. it is assumed that all scenarios will have equal weight. So that's the very simple way of putting it. No? An affirmative response to each of the statement would garner a score. Thus, the total score would range from 0 to 11. So following this scheme, the highest score is actually 6 out of the. So the maximum number of scenarios that they experience, stigma and discrimination scenarios that they experience, only 6. And so following this scoring scheme, what we did was 0 is low level of discrimination, 1 to 3 is medium, and 4 to 6 is high. So of this, 55% of the respondents were found to have low level of stigma and discrimination experience. So they did not experience any stigma and discrimination from the 11 scenarios that were presented, and only 11 experienced a high level of discrimination. So what we did is we tried to look at severity, the level by length of years as PLHIV, and here we found some interesting pattern. Those who had been diagnosed as PLHIV 1 year and less, they have the highest who said that they did not experience any the low level of discrimination compared to those who been PLHIV for 10 and or 10 years and more. Okay. So internalized stigma, this was mentioned earlier. So we also found this, that some measures of self-efficacy are not affected by HIV status. So respondents would still report the ability to cope with stress, to have close and secure relationship with others, to find love and contribute to the community. So another measures of internalized stigma is self-exclusion and deprivation. And here I bring in methodological aspect. Now, this is what I was saying, that it's so difficult to translate a negative. It's like a double negative. Choose not to attend social gatherings. It's a bit confusing to respond, especially if you translate this in Filipino. And so those are our concerns. That's why if you look at responses, it's really very low. It's compared to other measures, I think. I mean, if we phrase it differently, then maybe we would have gotten more responses. And also because this can also be cultural, Filipinos they don't respond to negative questions. So disclosing one's status in terms of internalized stigma, our findings was that disclosing one's status is still a difficult process. Majority still hide their HIV status from other people, and the feelings of guilt, worthlessness, and even being dirty are common among Filipino PLHIV. So encounters with healthcare care services. So here we see that there's quite an improvement compared to 2008. 8 in 10 choose to get themselves tested. 15% were tested without their knowledge, and only 5% were pressured to be tested. So when we asked in 2010 whether the choice to be tested was there, so only 56.3% said yes, and in 2019 it's already 80%. So getting tested appears to be a voluntary decision among PLHIV. More of those who are PLHIV for 10 years. I mean, length of being PLHIV is definitely a factor. Reported that they've been tested without their knowledge. I mean, the situation at the time is still different. So now it's not easy to do that anymore. So only 50% of those who have been PLHIV for 10 years and more reported that getting a test was a personal choice, compared to almost 70% among those recently diagnosed. 24% also said that they disclose their status when they go outside the treatment hub for non-HIV related concerns. 94% are confident that their medical records are being kept confidential. 1.5 reported that they were advised not to have a child by healthcare professionals because of their HIV status, and about 4% reported that they were told by a health professional that in order to get their ARV treatment, they had to use a specific method of contraception. So this is also another section of the questionnaire. This is quite difficult for us to ask. The human rights in effecting change. It's either because Filipinos are not really familiar with their rights, or And also because it's really closely tied to, visa, for example, and assuming that, of course, we do have a lot of Filipino overseas workers, so there are a special group of PLHIV. But here we do. That's why the responses are quite very low and really very low knowledge in terms or although 95% are aware that they're lost, no, but they don't know what these laws are. And when we conducted this 2019, the PLHIV Act was just enacted, no, in 2018. So it's still new. So this responses, for example, we really it's so difficult to get to get them to answer this kind of questions. So another question that was asked, how we're able to share the findings. We always highlight that, of course, data is important, and there's still a lot of although there's very low report of stigma and discrimination, we feel that it's more of the measure not being able to capture the experience of a Filipino PLHIV, because when we ask for case studies, for example, and when we ask respondents in terms of their very specific experiences, then that's when all these experiences of discrimination came out. So as I mentioned, I think our contribution here is really more methodological. So we have a lot of suggestions to GNP team at the time, because we also have issues with coding and the analysis itself. So, and I think that's from the Philippine experience. There are Filipinos in the audience, I think, that maybe are more familiar. My 10 minutes is up, so okay, go. That can help.
Did you hear the sound?
Explain.
Sorry.
I did. So
Sorry.
10 minutes is up.
Sorry.
So I'm
30
done.
seconds
Thank
ago.
you.
Thank you so much, Dr. Alma. And thank you for highlighting the research methodological perspective, because I think if you're going to share or to present data, I think it's good to present the realistic representation of the lived experiences of people living with HIV. And to note that this is 2019, so this is pre-COVID and pre-monkeypox era, and there might,
Yes,
as you've mentioned, there's a lot of things that already happened. There might be changes in the information if you're going to do the assessment again. And
Yeah.
I'm highlighting in my notes the methodological aspect. One of the limitations is the strict adherence to the structure or format, which kind of like limited the researchers in reframing or reformatting the questions. So
Yeah.
thank you so much. And we will be noting all your suggestions in terms of how we want the next stigma index will be. Yes, we have Filipinos in the room, and we also have a lot of questions in the chat. But we
Okay.
will have all those discussions later. Let's give chance to people, to our panelists to present their country context. Thank you, Dr. Alma. From Philippines, let's
Okay.
board the plane and let's fly to, where are we flying? We're flying to South Africa, and we are with Nuleki Zazini, from NAPWA, the National Director of NAPWA, to share the context of South Africa, on what are the significant trends revealed by Stigma Index and how did you use the findings in your advocacy. Nuleki, over to you.
Okay, thanks. Good day, colleagues. Thank you so much for inviting NAPWA to share our experience in South Africa in contributing in the fight against stigma and discrimination. I think it will be important to first thank our technical supporters, which is the Human Science Research Council and the South African National AIDS Council, including the Global Fund, PR, which is the AIDS Foundation of South Africa, who provided some resources to support us as people living with HIV to do the stigma index research. I want to apologize for not sharing my presentation as I am experiencing some challenges, but allow me to go through it. I think in answering the first question, in answering the first question, I think the recent stigma index results do highlight that there's a decline in terms of the external stigma. And while we say there's a decline in terms of the external stigma, we also want to highlight that it has not gone. It is still there, especially for a key population. And it's something that we're not proud about it, that we think we really need to make sure that we continue developing some interventions that seeks to address it. We also have internalized stigma that continues to be a huge issue that deeply affect people's confidence in relationships and self-worth. This is particularly true to young people and key population like sex workers, transgender individuals, and people who use drugs. We also have some issues related to healthcare settings where it remains a significant concern, especially people living with HIV who continue reporting issues of judgmentality behavior from the healthcare providers, which are leading for people to delay taking their treatment and even interrupting their treatment altogether, especially women in particular, who are most affected by stigma from healthcare staff. This is something that as PLHIV networks, we really need to design some programs to address this. Then the other thing that is coming up is the issue of disclosure of status. While we understand that disclosure of HIV is voluntary, but what we are seeing, especially in the professional settings, like workplace and in schools, it remains very low. And there are concerns in some instances where some people are disclosing one's HIV status without consent. So it's one particular area that we need to make sure that we design some programs to address this problem. We are also seeing multiple stigma and discrimination around a key population because of sexual orientation and because of one's HIV status. So we want to make sure that we engage directly with key populations so that they can inform interventions that seeks to address these challenges. In the recent Stigma Index 2.0 that we have just launched in December, the other thing that is coming up, it's a TB-related stigma. And it's really a challenge. At some point, people that are affected by TB, it's really difficult for them to take their treatment because of stigma. And then there's a question around how do we use these findings as PLHIV networks. In South Africa, we have about 5 national networks. NAPWA is leading, has been given anyway a mandate by these networks to conduct this study, which is Treatment Action Campaign, Positive Women's Network, Positive Action Campaign, and the religious leaders who are affected and infected by HIV and AIDS, which is SANARELA. So we're using these findings for advocacy on policy brief. Our focus is on internalized stigma and healthcare stigma. We want to make sure that we develop some comprehensive anti-stigma trainings so that we can train the healthcare workers to address these challenges that we see through these findings. We are going to develop and scale up community-led interventions for internalized stigma, focus to address high rates of internalized stigma, especially among young people and key population. We also want to strengthen legal literacy and rights. We want to empower people living with HIV about their rights related to HIV status so that they can be able to challenge these issues. Because we see that even at school, people living with HIV, they are experiencing more stigma in the education settings. We also see that a key population and people with disability are experiencing a double stigma and discrimination. So we want to ensure that these communities, we directly engage with them and making sure that they're actively involved in designing programs to implement them and evaluate those interventions to address the double stigma. We are going to continue with our public awareness campaigns, challenging these stereotypes at community level and empower our communities so that they can understand issues of human rights, that people living with HIV are humans too. They are now to engage with our government using these findings. We have developed a comprehensive policy briefs looking at health and key population. So the other issue, we are going to request a high-level meeting where we are going to meet with the Social Development, Department of Justice, and Education and the parliamentarians, so that together we can sit down and try to work on policy reforms to address issues that are affecting people living with HIV in the country in terms of stigma and human rights violations. We have started engaging with media in terms of dissemination for these findings. There are a lot of interviews that we have conducted during the launch of Stigma Index. We are going to make sure that we reach out to all the sectors that are affected in this study, especially the key population, so that we can also hear their voice. Now we are in the process of going to provinces and districts for dissemination of these results at provincial level and district level. 2 days ago, we have just engaged with one of the PRs of Global Fund to say it can be correct that they can appoint a consultant to work on developing advocacy programs without us. So a cheaper principle needs to be observed. So we have pushed that there must be a review of those terms of reference and include our co-principal investigator, who is a person living with HIV, to be part of the process so that we can inform the advocacy interventions that seeks to address stigma and discrimination in the country. So they have agreed to work on reviewing those terms of reference. Thank you.
Thank you, Muleki. Muleki, there's a question for you in the chat. So you're stating that programs should be designed to combat stigma. So Dorian is asking if you can elaborate on how these programs will assist the eradication of stigma. And if you have any examples, if you can share some of these examples.
Okay, let's first talk about the internalized stigma. On internalized stigma, we believe that it's important to first engage with people living with HIV direct, so that they can share with us what are the problems for them that makes them to have these fears of disclosing their status, and then in a way try to come up with some solutions. They must try to provide as well some ideas on how to do that. But what we think that is important for us to do is to empower people living with HIV about their status, is to empower people living with HIV about their rights, on how to claim their rights. But in the process, we must also making sure that we protect their rights, because there's no one who must be forced to declare their status. If people they are not ready to declare their status, we must accept that. But in the process, let us try to make sure that we educate them. We have people like me that are openly living with the HIV. These are the people that goes to a community. These are the people that goes to people living with HIV, especially the newly diagnosed, telling them about this experience. When we started disclosing our status, these were the responses from our communities. There were negative responses, there were positive responses, so that people can decide what to do. But in the process, it is important for us as people living with HIV to make sure that we empower people living with HIV while we are protecting their rights, so that in future they can be able to stand for their rights. And we fight stigma and discrimination, because we want to see a stigma-free society in our country.
Yeah, thank you so much. There's still a lot of questions in the chat. Please keep the chat coming. Please keep your questions coming. We also have Q&A box where you can also share your questions to the panelists. We have one last, thank you, Maleki.
Thank you.
And thank you so much to our participants who are very active at the chat at the moment. We have one more panel member who will be sharing the country context now in Sierra Leone. So Martin Philip Eli is from the network of HIV positives in Sierra Leone, and will be sharing the context in the country. Martin?
Thank you very much. It is a beautiful morning here in Sierra Leone, and good evening or good afternoon, wherever you are. And thank you to GMP Plus or the conveners for giving us the opportunity to share with you in this webinar. So I did not prepare a presentation, but I will be speaking to the issues directly or the question. So stigma and discrimination remain significant barriers to the HIV response in Sierra Leone. It limits service uptake, delays treatment initiation, disrupts retention in care, and weakens effort toward epidemic control. The PLHIV Stigma Index study has been very instrumental in helping Sierra Leone explore the perception of people living with HIV on stigma and discrimination here in this country, in Sierra Leone, and to gauge the trend as well. The study has provided evidence which we have used to inform policy engagement and to also shape program interventions. For you to know, Sierra Leone has conducted 3 rounds of a stigma index study, with the most recent published in 2025 by GMP Plus. Thanks to GMP Plus for their incredible technical support. From the findings, our attention was drawn over the years from the different studies. Our attention was drawn to trends related to stigma, the healthcare settings, disclosure, rights abuse, and ability to take action. Each of these areas I want to explore quickly, focusing on specific issues that have shaped our intervention here at country level. So stigma at the healthcare settings is shame of being among PLHIV visiting health facilities where life-saving services are provided. From the 2024 study, which was published in 2025 by GMP Plus, about 56% of respondents delayed treatment initiation because they fear that people they did not know or relate with would discover their HIV status.
Martin, sorry.
While 58% delay treatment due to worry HIV status. Compared, hello?
Hello, Martin. We cannot hear you. Maybe it's better if you
Can you
maybe
hear
it's better
me?
if you turn off your video. We can hear you now, but your video
Can
is
you hear me?
frozen. Yeah, yeah. I think it's better now. Yeah.
Oh, okay. My video instead?
Yes, yes, that's better.
Can you
Yeah.
hear me now?
We can hear you now. But a little bit
Can you hear me?
erratic. Yes, can hear you now.
Yeah,
You can continue now, Martin.
probably it could be as
Yeah, I think he's still cutting. Oh, we lost him.
Let's
of the
let's
connectivity. So I don't know where you lost me, but
you're out
can you hear
again.
me?
Yes, you're in again. We can hear you now. But while waiting for Martin, let us know if you're already back. But while waiting for Martin, we uh we want to read some of the contributions of our participants in the chat. So from Mohammed Tadsi, saying that zero discrimination is not only a slogan, it is a daily commitment. We must invest in education, awareness, and communication to dismantle false ideas. As PLHIV leaders, we declare we have lived stigma and we will change it. Yes, we will change it. Together with science, with human rights and solidarity, we can build Morocco where every person living with HIV is respected, protected, and proud. Thank you, thank you. Thank you, Clayton, for joining us. Martin, are you there?
Yes, I'm here. My apologies.
Okay.
I think the internet connectivity is indeed very weak. So I don't know where you lost me, but let me just continue.
Yes.
So so from the 2024 study, I was saying about 56% of respondents delayed treatment initiation because they fear that people they did not know or relate with will discover their HIV status, while 58% delayed treatment due to worry that family or friends will find out their HIV status. So comparing that to 2020 study, we noted that 5% reduction in delayed treatment initiation for fear of people that did not know, and 2% reduction for fear of their family or friends. So similar patterns we observe as well in treatment interruption and re-engagement in care. From the same 2024 study, 55% interrupted treatment because they were worried someone will know they were HIV positive, while 68% hesitated or delayed returning to care for the same reason, not being discovered as HIV positive. So, but in addition to avoidance of physical contact by healthcare workers, there are also other key concerns revealed by the study related to stigma at the health setting, which was disclosure of HIV status without the consent of recipients of care. That one accounts for something like 3.3%, and also being gossiped, about because of their HIV status, which accounts for something like 4.1%. Now, in that same vein, the study revealed that disclosure remains difficult for many recipients of care. Nearly 85% disagreed that disclosing their HIV status has become easier. But mainly, people within the age bracket of 18 and 34 years indicated that disclosure was a challenge. So instead of seeing reduction in this area, we have seen about a 38% increase compared to the 2020 study. Now, the studies that we've been doing have also revealed rights abuses within the past 12 months, with approximately 12% experiencing compulsory HIV testing when seeking employment, while another 12% reported compulsory testing while applying for admission to educational institutions. So, but regarding taking action or responding to right abuses, 51% in the 2024 study indicated that they did not know where to go to take action. Of concern also is the ability or willingness to seek justice among the key population groups after right violation. And we noted that 83% of MSMs and 65% of sex workers indicated that they did not try anything, to seek justice. Now, these findings, as I've just shared, point to structural discrimination and weaknesses in the enforcement of existing policies. They also demonstrate that stigma within healthcare settings, combined with negative attitudes at the community level, perpetuates fear, shame, and silence among people living with HIV. As a result, individuals are less likely to openly seek, access, and fully engage with HIV treatment and care services, right across the countries. So with these findings, we have developed programs actually that enable people living with HIV access care and to engage in activities that are rewarding to themselves and families without being stigmatized or discriminated against. So in this regard, we have increased, the number of support groups from 70 to 102 in 2025, expanding reach for support groups to all districts in Sierra Leone. Specifically, we all know that support groups provide safe space where people living with HIV receive psychosocial support, share experiences, discuss disclosure challenges, strengthen treatment literacy, etc., so that they remain in care. Also, we currently implement an integrated community-led monitoring, which helps us to generate evidence from service users, document discrimination, assess confidential practices, and identify gaps in delivery of services. This approach ensures that the voices of people living with HIV and key population directly inform the quality of care that they receive at these health facilities. So finally, another thing that we've done in terms of program is that we have established a call center which we use to receive and manage reports of right violations and abuses affecting people living with HIV and key population groups. So these reports, which we receive, they are investigated, documented, and then some are referred for litigation. So in just this 1 year, 2025, our call center received up to 53 cases related to right abuses or violation. Out of the 53, 41 cases were resolved through alternative dispute resolution or out-of-court settlement. 5 cases were sent to court. Out of those 5 cases sent to court, 3 received justice, indicating that they all won their cases, and the rulings came through the magistrate or the High Court of Sierra Leone. Finally, in conclusion, the Stigma Index study has really offered us here in Sierra Leone with actionable insight. It has revealed how right abuses, fear of disclosure, stigma in healthcare settings directly undermine HIV service uptake and impact on people living with HIV. Importantly, it has also guided strategic investment to create safer, more responsive, and right-based HIV programs. Thank you, and over to you.
Thank you so much, Martin. I don't know how to remove the time. Oh, my timer is removed. Thank you so much, Martin, for that. And apologies, sorry for the IT disruptions. So from our speakers, we have kind of like highlighted that there's a common concept or common how to say that findings on internalized stigma, and there's the fear of involuntary disclosure from people living with HIV. And we have also highlighted policy level discrimination and structural discrimination, especially at the healthcare settings. Now we're going to the question and answer, and I'm inviting our panelists to kind of like jump in and share your thoughts. And thank you to those who've been actively sharing your questions and thoughts in the chat box. So we have this question in the Q&A from Tinashi. how can PLHIV Stigma Index evidence be most, or how can the evidence from the PLHIV Stigma Index be most effectively translated into funded and community-led access to HIV services for key populations, particularly in contexts where criminalization operates at the grassroots level? Can you see the question? So maybe from your experience, how can we, or maybe we can rephrase this question, how can we translate the findings of the Stigma Index into funded and community-led programs that expands access to HIV services?
So probably I will go first, if
Martin.
and then the others will come in later. So here in Sierra Leone, the activities or orientations of key populations, particularly men, MSMs, are criminalized actually. So, but we have used the public health approach by way of establishing what we call drop-in centers. So now the drop-in centers are used right across the country to provide services, you know, to key population groups, including the MSMs, sex workers, and then people who inject drugs. And we are seeing, based on the data that is coming through, that these drop-in centers are helping immensely to reach these populations, which tend to be criminalized by our laws, especially the MSMs, because here in Sierra Leone, it is criminalized under the sodomy law. But then for sex work, it is more of loitering. It's not really the sex work, but loitering. So, but then we are using the drop-in centers to reach out to them and ensure that they receive services. And we are being informed by the Stigma Index study. Thank you.
Thank you, Martin. We have other responses to that question. How can we use Stigma Index to be effectively translated into funded and community-led programs? Okay, so the next question is about the data on gender. So is there a relationship between gender and HIV-related stigma and discrimination? How do the numbers show which gender is more susceptible to stigma and discrimination? I think I can ask Dr. Breck or Dr. Elma from your presentations. Are there data that presents the relationship between gender and HIV-related discrimination?
Yeah. In the Philippines, I think because the respondents that we have is disproportionately female. So in terms of experience of stigma and discrimination, we see, for example, the females, because most of them are into commercial sex work. So it's the discrimination that because of being PLHIV, it's really because of being a sex worker. So I think that's the difference with male. It's the same thing being talked about as being gay man, or being someone who have sex with men. So it's more than that, I think, rather than being PLHIV.
Thank you. Dr. Breck, do you have some information that you can share from Kazakhstan about the relationship of between gender and HIV discrimination?
I apologize. Please repeat the question.
So there was a question asking, is there, from your presentation, is there a relationship between gender and HIV-related stigma and discrimination? And which gender is more susceptible to stigma and discrimination?
Yeah, thank you for the question. Yes, we see in various aspects of stigma and discrimination, gender difference, and more female affected by discrimination, but we see in some aspects even men affect more than women. So as for TB, in 2024, Central Asian Association conducted TB Stigma Index. And yes, some of the respondents were PLHIV. So there we saw that TB stigma is more affected PLHIV than just how to say ordinary TB patients. So yes, my answer is yes.
Thank you. Maybe from South Africa, Luleki, is there information from your findings about the relationship between gender and HIV-related stigma discrimination?
Yes, it is there. And for South Africa, most people that are affected by stigma, it's women, and particularly those living with HIV, because they put blames, and it also affects their moral as well. Some they tell us that in a process of disclosure for their status, they experience issues of violence and abuse. Then they ended up having internal stigma. But when you go to men, it's more of norms like traditional beliefs, and naturally men, they have that ego of late healthy seeking behavior. So it's all around that. Mostly it's women that are affected. And then you go to key population as well. They are experiencing stigma double because of their sexual orientation. Hence, I think in the recent results, it is there that in terms of gender, there is data or evidence that we do experience stigma differently in terms of gender. And mostly people that are affected is women. Thanks.
Yeah, thank you. And I think from different countries, different information or different context, we can see a variation of information or data about the relationship between gender and HIV-related stigma. And in some contexts, maybe there will be a lot of HIV-related stigma against women. But I think we have to look at the information or the data from different stigma index studies that has been conducted from across countries to kind of like extract that information specifically. We have invited several people to be in the floor. And I have invited specifically Erwin from the Philippines. You might want to share something on the Philippine perspective on stigma and discrimination.
Yes, good day to everyone. I am Erwin. Everybody calls me Natsu here. One of the leader here in Philippines, community leader. So I see in my long run in the program as in the community that internal stigma really affects especially the newly diagnosed, since we do not have yet internal index conducted in latter part, in 2022, 23, 24. We don't have that one readily made, but it is ongoing, but as I observe as a community leader, as a PLHIV itself, and as a counselor, that in here in the Philippines, the internal stigma really arises. Why are there people living with HIV and increasing of loss to follow up here in the Philippines is because also of the internal stigma. And because of this term internal stigma, accessing to testing is hard, especially on our transgender women and our young key populations, no? And moreover, it really affects the health-seeking behavior of our PLHIV and also the key populations to access testing, to access ERV adherence, ERV, and the adherence really the adherence really slowing down some of our people living with HIV because of that notions in their self, that stigma in their self, that they are being, that they think that they are tawag nito, they are what you call this, dirty, they're gays, you know, they are especially on their gender, you know, afraid of what their family will be said to them. So that accumulate more of the behavior of our people living with HIV, especially develop that internal stigma really affects on their health-seeking behavior. And of course, the policy itself here in the Philippines, it's quite a need to improve more, especially on the local policies and in the local governments here, that there are still no strong holds on the policy that should be that should be implemented, and that should be help our people living in HIV to continue their lives. Over.
Thank you, Natsu. Thank you, Erwin. And thank you for sharing the perspective on internal stigma from the Philippines. We have also invited Randy. So Randy, you have entered your question, but I think it's better if it's coming from you. So over to you, Randy.
Thanks very much, Annette. I appreciate the opportunity to speak on the call today. So I'll just read what I wrote in the chat and what I also wrote in the Q&A. So across different countries and contexts, I'm always struck by how familiar the challenges feel. The geography may be different, but the stigma, the misinformation, and discrimination show up in many of the same ways. And here in Canada, the context may vary, but the barriers that people living with HIV face are not so different from what many others are experiencing and talking about today. That shared reality, though, is also our shared strength. And I truly believe that when we lead with lived experience, defend the science of U equals U, you know, I can't make a comment without talking U equals U, and stand together across borders, we move closer to a world free from discrimination. So my question is, in today's political climate, where resources and rights are under pressure in many places, what actions are most important to protect and strengthen the leadership of people living with HIV? Over.
Thank you, Randy. Does anyone from our panel want to share their thoughts on that? I can share my thoughts on that, maybe to start. And maybe I'll ask our colleagues from GNP Plus to share their thoughts as well. So I think the question is about the protecting and strengthening PLHIV leadership. And I think from the different news that we're hearing at the moment from the political and the funding landscape, the geopolitical and the funding landscape changes and the shifts, I think first we have to ensure that the civic and political spaces where the people living with HIV convene and gather or operate are protected. One of the examples that I can provide is this convening. So if we have this convening every time, and we kind of like make sure this convening does not shrink and does not affect or expand the security of PLHIV leaders, where they can convene and gather and share ideas or share strategies. I think that's one of the actions that we can take. The current or the ongoing geopolitical and funding shifts does not only affect the work that we do, it affects us personally, because this is our identity. The work that we're doing as PLHIV leaders is intimately linked to who we are. And so when we see this news, we are emotionally affected. So therefore, we must have this opportunity or space to hear from each other, to make sure that we are sharing information, that to morally support each other. The second, I think, is to make sure that the organizational security is also addressed. A lot of our organizations are currently in well, if I can say, face of currently facing challenges. It's not only at the global but regional, but also the national level, most especially at the national level. So there are the security in terms of financing, security in terms of sustainability, security not only about the organizations but personal security, the digital security, and having to address those security issues at the organizational individual level would also kind of ensuring that we are protecting the leadership of people living with HIV. One of the things that I can also think is to make sure that we are strengthening the collective leadership. From this convening, like what do we get out from these discussions? How does our collective leadership look like? When we talk about the next iteration of Stigma Index, how does our collective PLHIV leadership contribute to the development of the next iteration of the Stigma Index? I would like to link that to the first question of Tinashi, transforming the evidence from the Stigma Index and how can we translate it into funded community programs. That collective PLHIV leadership can actually help translate the research into tools or into programs according to different contexts. As what Clayton has mentioned earlier, the Stigma Index is not only a research, but it is a tool to change policies. But what does it look like? How do we make those programs, or how do we design those programs or interventions a reality? So number one, if we are talking about internalized stigma amongst people living with HIV, as we have lived this kind of experience, and as we have gathered professional expertise in HIV programming, how do we translate this finding that there is high level of internalized stigma among people living with HIV to design a program that can support people living with HIV address their internalized stigma? How do we design this, or how do we interpret this research finding into a program that is actually working with the policy or legal systems of a particular country to make sure that there is no structural discrimination or structural violence, and enable the people living with HIV at the grassroots level to access treatment or access services. So the question is very broad, but I think if we go deep, and as everyone has mentioned, lived experiences, how do we use our lived experiences to make sure that we are translating that we have experienced it, and therefore we can change it by translating what the research is saying into a very effective and useful program at the country level. So we at this convening level, at the global level, we cannot really say like, okay, we can do this, we can design this into this, we can design a program to address internalized stigma like this, because different countries have different contexts, and it's not only political but also cultural landscape we have to look into. And I think this the PLHIV leadership that we're talking about can actually help in designing those programs. And I think Bieng in the chat has a very good question and a very good point, because the opportunity at the moment is the Global Fund Grant Cycle 8. And how do we use the research findings, and how do we translate those findings to make sure that there is allocation towards initiatives aimed at addressing discrimination related to people living with HIV. And I think that those discussions will be very helpful moving forward. And I think from the GNP Plus perspective, we are looking at how are we making the next iteration of the Stigma Index really responsive to the context of people living with HIV. So those are my 2 cents. But thank you so much. Thank you so much for the questions. Okay, we have come to the conclusion of our convening. Anyone from our GNP colleagues would like to share? something points?
Yeah, sure. Thank you so much to everyone, to all our speakers. I think we have learned a lot from the country level, looking at so many similarities in terms of the experiences and the process of the actual PLHIV stigma index itself, and also the responses in terms of the findings and the realities of where stigma lies. Even though there is some aspect of the index reduction, it doesn't take away from the reality of stigma being still very high in certain spaces for self-stigma and for people from key populations, among other things. I think I see some people on the chat indicating their questions weren't answered. I believe this is just an opportunity to start the conversation, and we are happy to keep it going. I think in terms of just answering some of the questions towards the end, and just to pick up from what you're speaking about, Inad, I do believe that in this time of global, national, broad public health and HIV transformation that is currently ongoing, there's an opportunity for us to work hard to secure the component of people living with HIV stigma index, or a key aspect of addressing stigma and discrimination in our access to treatment, our access to prevention and to testing. I think in these times, we've seen from last year with the shifts in funding and the prioritization that stigma index was one of the things that were quickly deprioritized, looking at the prioritization process at country level. So I think we have a little bit of work ahead of us to make sure that the adaptations and the reforms currently going on understand the impetus and the matter of stigma and discrimination as it affects and impacts our lives directly and that of our communities. I think it's a moment to take stock what the work we've done so far has yielded, what the lessons we have, what the indicators and the index provides in terms of findings and data. But also it's a moment to take stock of the opportunities. And I foresee that this is a critical component of doing that. We've just had the UNAIDS launch this week the Global AIDS Strategy 2026 to 2031. And on there are the 10-10-10 targets. They are still in there. Their indicators are further refined. As we are going towards the high-level meeting on HIV, where we are hoping to have the political declaration shared on HIV, we must make sure these indicators make it to the political declaration, because that will be the foundation of ensuring that this goes to the country levels. At country level, the GC8 applications, people are preparing for those. How do we work together to make sure stigma is put in the plans and the applications of the country? The national strategic plans all absorb indicators for stigma. We must make sure those are retained and are going towards and aligning with the 10-10 targets. And then finally, the countries that are signing MOUs with the US, the implementation plans must make sure that they significantly also contribute to this. So for me, I think this is a start of a conversation about thinking about stigma index in the transformation currently ongoing and the iteration as Inad talked about. I think just to say from our GNP+, we are looking to do this year with you all an evaluation of the current people living with HIV stigma index, to take stock of what we've done, what we have, the things we cannot afford to lose, the standardization process that we've had across the countries, the fact that the indicators are sitting in the GAM, in the UNAIDS, and countries must report on them, has been a significant opportunity for our advocacy, and all of these things that we must secure as the adaptations are going on. Please stay tuned for this piece of work to do with us. We are hoping that this report will be our World AIDS Day report for 2026. So this is another year of coming together to do something more important with evidence from all of us together. Thank you so much, and back to you, Inad.
Thank you so much, Florence. And regarding internalized stigma, I think I have to, as a person living with HIV, regardless of the number of years that we have been living with HIV, internalized stigma is a process. It is intimate and it is not performative. Different people address internalized stigma differently. It's linked with trauma, it links with personal identity, it links with shame, it links with family, sexuality. There's a lot of personal aspects, and I think if we are going to deep, if we really intend to deep into the internalized stigma of people living with HIV, we have to have a different format, not like this. Because we are opening up a personal Pandora's box, and I think that's something that we have to consider if we're talking about internalized stigma. And I think as of the moment, speaking personally, on a personal level, there's still conversations on how to address internalized stigma, because it is not easy to address. It's something personal, it's something intimate. It is not performative, and that's what I would like to say. Thank you so much, everyone, for joining us today. We are happy that you have engaged with us actively in these discussions, and we would be happy to see you again soon in the next PLHIV convening. Have a nice day, everyone. Bye bye.
Thank you, everyone.
Thank you. Bye bye.